Okay, well, welcome everyone to today's distinguished speaker series, and also as an aside, happy International Day of Women and Girls in Science, just today. And we're really fortunate to have with us today Dr. Seema Clifasefi from the University of Washington. Dr. Clifasefi is an associate professor and co-director of the Harm Reduction Research and Treatment Center at UW in Harborview Medical Center. And she received her MSW from the University of Washington, as well as her BA, and then completed her PhD at Victoria University of Wellington in New Zealand before going back to UW. And Dr. Clifasefi's research sits at the intersection of substance use, mental health, criminal justice, and housing policy. And for the past 2 decades, she's led academic and community-based research partnerships focused on the development and evaluation of harm reduction programs and interventions designed for and with people who have lived experience of homelessness and substance use problems. And I've had the pleasure of knowing Seema since 2003. We figured out this morning. So that was when Seema came back to UW to start a postdoctoral fellowship with Alan Marlatt. And I was starting my first year of graduate school at that time. And so we were both in the ABRC there. And as some of you know, Alan Marlatt is one of the most influential and innovative scientists in the addiction field. And he was one of the early proponents of the harm reduction movement in North America. And so Seema conducted innovative work with Alan. And when Alan passed away in 2011, Seema and her colleagues really carried the torch in terms of maintaining a strong harm reduction research profile at the University of Washington. And she's led and co-led numerous innovative projects in this area, in the Seattle area and elsewhere. So we're really happy to have Seema here today, and she's going to talk with you about meeting people where they're at, community-engaged research with individuals with lived experience of homelessness and substance use problems. So thanks, Seema.
Thank you so much. Well, it's so fun to be here, and thank you, Christian, for reaching out and inviting me. It's fun to be here at USC. I was sharing with Christian this morning that my dad is an alum of USC and also taught here. And so we have a Husky USC Trojan rivalry a little bit. But I learned today that a few members on the Seattle Seahawks are ex-Trojans. So now we can be a house united. And my dad's claim to fame is O.J. Simpson was one of his students. So that is the story. I've never actually fact-checked that. So thank you so much. I'm really excited to talk about the work. I just came from doing rounds with the street medicine team. So didn't have time to change, but I'm like, this is okay. This is what I wear every day anyway in Seattle. And before I get started, I just wanted to take a second to acknowledge that the Seahawks are Super Bowl champions. I see some familiar faces from Seattle here. So it's a really big day in my hometown of Seattle. As we speak, about 1 million people descended on the city today, lining the streets to celebrate the win with a victory parade. And I also want to acknowledge there's probably about 20 of us here making better decisions. So I'd argue that we're the real champions here. But seriously, thank you so much for coming to my talk today. I've long admired the Keck School of Medicine, Dr. Blumenthal, and many of you here in this room right now, and just happy to be here sharing, exchanging knowledge. Everything I do in my work is bi-directional. So I'm learning as much being in the field, working with participants, and talking to individuals as much as I'm sharing information. And yes, as Dr. Hendershot mentioned, I started as a postdoctoral fellow at the Addictive Behaviors Research Center back in 2003. Were you there?
2007.
2007, okay. Completely lost track of time. I cannot believe it's been over 2 decades. And I also had the pleasure of serving as Dr. Shane Collins's mentor, who I just got to do rounds with. So that was a really fun experience this morning. Okay, so Seahawks champions. Now let's talk about people experiencing homelessness and substance use problems. So I just wanted to start by sharing a little bit about what we do at the Harm Reduction Research and Treatment Center, or the HaRRT Center. Our mission is really to work collaboratively with people who use substances, as well as community members, excuse me, and organizations who serve these individuals, to develop, conduct, evaluate, disseminate evidence-based interventions that really are in service of reducing substance-related harm and improving quality of life. Also promoting social and racial justice and equity for affected individuals and their communities. And our overarching, I don't know, there's a tomato there, is really to reduce harm, strengthen communities, and improve lives. We recognize we cannot talk about substance use without talking about all the racialized drug policies and harms caused to people of color through the implementation of these policies and through our work. We really work to try and undo these harms to the extent that we're able in our roles of privilege. So at the HaRRT Center, we have adopted really a community-based participatory research framework with the intention of breaking down structural barriers in the research process and doing what we can to promote equity, autonomy, self-determinations amongst the communities that we work alongside. And we really try to we are striving to facilitate transformative and sustainable change in a way that lets the communities set their own goals and their own agendas and speak on their own behalf about the things that are important to them. One of the things I have learned through this work is, as researchers and clinicians and professionals, we have to be better at listening to what the communities tell us and being guided by that. And then the other thing that I've learned in this work is that the collaboration, no worries, the collaboration itself, working alongside communities with lived experience, with lived expertise, is actually one pathway to healing and achieving that social change. That is probably what I've learned the most through this work. I was not trained as a community-based participatory researcher. In fact, I'm a cognitive and experimental psychologist by PhD. And so really did a pivot as I was sharing with Christian in the car. I came to do a postdoctoral fellowship with Alan Marlatt back in 2003. And he just had this like very open approach of like, come to every single meeting with me and let me expose you to all these different things that we're doing. And it was in those moments that for me felt really transformative, started sitting across from people with lived experiences different than mine, and just being in proximity with communities that we were working to serve kind of allowed me this true shift in my training to treat the individuals that we're working with as experts in their own lives, and experts in the subject matter that, you know, many of us maybe do not share those exact lived experiences. So I sort of shifted. You talked about, you know, my MSW, but actually I got my MSW. I'm a licensed clinical social worker now, 14 years after my PhD, because I was working in these spaces, very clinical spaces, working alongside people struggling with substance use, and developing interventions to administer to these populations. And I didn't actually have the clinical training that went along with that. And so my partner and sister in science, Dr. Susan Collins, is a licensed clinical psychologist. And so we were like, well, how do we capture the market here? So I went back and did a MSW in social work, because that was really kind of the ethos and the value system, and kind of working on a larger sort of community level. And that also allowed us to supervise not just clinical psych students, but clinical social workers and public health folks and things like that. So We are a interdisciplinary mix at the Harm Reduction Research and Treatment Center. And yeah, I start telling stories and then I sort of lose track of where I'm going. But in any case, this research paradigm framework of CBPR really allows us to integrate and involve community voice and create interventions that are with, by, and for communities while still maintaining scientific rigor. So we've sort of adopted this approach just overarchingly, where it's a multi-phased approach where we spend a lot of time listening to the community, being in proximity to the communities that we're working alongside, and hearing what their concerns are. What are they thinking about? What do they want to see for the community? How can we lend our expertise that we have to come up with some shared approaches and ideas? And then taking that information and developing different services, treatments, programming alongside the community. So developing community advisory boards who guide us and keep us accountable in the work that we're doing, tell us if the fit and the residents and the acceptability and feasibility is all on track, or tell us if we have to scrap it and start over. And then once we develop that together alongside community, then really using mixed method research design, so both qualitative and quantitative, to test treatment efficacy and better understand mechanisms that are happening. And then phase 4 is really disseminating and implementing treatment and programming sustainability. I think I'm now at the phase in my career where I'm really trying to work towards dissemination and implementation, because we do this work in community because we do not want it to live in the ivory tower. And we want communities to feel ownership over what it is we're doing, and investment in that. And so I see the next kind of latter part of my career really just spending time working in communities to try and adopt these models. And even just in the morning rounds, just talking about some of the offerings we have in terms of harm reduction treatment, a model of talking to people differently about their substance use, without judgment, with compassion, with practical kind of evidence-based ways to help people stay safer and healthier if they're choosing to be in relationship with substances. That's a very different treatment model than most of us are exposed to, or the status quo, where really you have to be willing to be abstinent in order to receive treatment. And I don't think I have to talk to this team about harm reduction. You have some incredible harm reductionists here in your space. But that's sort of where I see myself spending some of my efforts. And over the last 7 years, I was recently appointed as the director of a program called the Doorway Project, and that is a shift away from adults experiencing homelessness to youth and young adults experiencing homelessness. So this is the University of Washington and the state of Washington's effort for the UW to play a larger role in addressing solutions around homelessness. And so I think the reason they tapped me is because of my work, working alongside people and really engaging and centering the voices of the community members that we're working to serve. So we have a youth advisory board. They definitely tell us what's up. And I'm taking a lot of the work and the research that we have developed and bringing it into the space. We have a collective space, kind of a collaborative care model where we've got medical professionals, behavioral health folks, housing and shelter people all in one space. And very similar, I think, to what the street medicine team is doing. You know, you go out with the MD, the psychiatrist, and the social worker, and then other peer support folks. So we're really trying to kind of bring that model to just the youth and young adult homelessness space, and putting into practice what we've learned, what we know works through the science, because I am still guided by science, even though that might not be where the current climate is at the moment. So my entry into this work really began at the intersection of alcohol use and chronic homelessness, which is a very vulnerable meeting point. It was for me being in proximity with getting to know and being inspired by the community, primarily people experiencing homelessness or who had the lived experience of homelessness, who had just moved inside. That led myself and my colleagues working in these spaces to adopt that sort of community engaged framework in the first place. But just before I kind of go deeper into that journey, I just wanted to start with some definitions. So chronic homelessness is used to describe people who have experienced homelessness consistently for at least a year or have 4 or more episodes of homelessness in the past 3 years, while also struggling with a disabling condition such as serious mental health, substance use disorder, or physical. And as you can see with this pie chart, people experiencing chronic homelessness are only a piece of the pie. 17-ish% of folks that are in this fall into this category. And some people have said, like, why the focus on alcohol use and homelessness? We do know that they are co-occurring conditions with real consequences. So we know the prevalence of use amongst people experiencing homelessness is estimated to be as high as 80%. And the prevalence of alcohol dependence in this population is about 38% worldwide. And just to give you a little bit of perspective on that, the prevalence of alcohol dependence in the general US population is about 3.8%. So this is approximately 10 times that of what we might see in a more broad US population. We also know alcohol dependence is associated with increased morbidity and mortality. And in addition to creating problems for the affected individual, consequences as a result of alcohol use can place undue cost and utilization burden on healthcare systems. And this really goes for all substances, but since alcohol was my primary focus and that was Dr. Marlat's primary focus, and many of us who were at the Addictive Behaviors Research Center in those early days, that was really my entry point into this work. Dr. Marlat and our colleague Mary Larimer were invited to do a larger evaluation of a trial I'll talk about in a minute, and I got to be very involved in that trial. So you might be thinking, okay, well, then the next logical step would be to offer more severely affected individuals, such as people experiencing chronic homelessness with alcohol use disorders, like abstinence-based treatment. And although abstinence-based treatment may be the treatment of choice by many providers and medical professionals, particularly for more severe populations, research has shown that most people experiencing homeless either never go to or turned away from or drop out of abstinence-based treatments that are available. They're often deemed as non-effective, acceptable, or desirable by this population. And in fact, not only are they not highly effective for this population, the few people who are engaged in treatment tend to drop out very quickly, and treatment for individuals experiencing homelessness often entails, as we talked about, abstinence-oriented philosophies. And so we know that even medically supervised withdrawal from alcohol or detox, the more often a person goes through that process to become abstinence, the more their brain goes through sort of these electrochemical changes that can lead to what's called a kindling effect, and can actually make subsequent withdrawals increasingly severe. So it could actually have an iatrogenic effect. So I guess I'm trying to say that, in other words, a huge a huge proportion of the population are missing out on ways to improve their health and well-being because the models that currently exist or that are the dominant models are not reaching them. So we need to be open to other ways of supporting people who need help around their substance use. So the work over the last, I guess, 20 years really indicated to our team the gaps in the treatment system for those who arguably needed it the most. And highlighted this additional need for and pathways to recovery for this population. And so we believe that a harm reduction based approach could provide one of those pathways. And in fact, the community told us that that was so, and I'll talk a little bit about that. So how do we get there though? So this slide shows sort of a toolbox of interventions and studies that we've co-conducted with community, all with the purpose of reducing substance-related harm and improving quality of life for the individuals that we're working with. As I mentioned, so just at risk of repeating myself, we do work collectively with the community to find out what's of most importance to them, what they believe will work, will not work, what's acceptable, what's feasible. And then based on those responses, we work together to build those programs and with the guidance of the community, and then we test those programs. And I guess the key piece there is the guidance from the community. So I see my role as being accountable to people and the community. And I'm really happy to report that our science has showed that our harm reduction modalities have been very effective. So we have developed a treatment model, 3-component treatment model, which I think I have some slides around that. But we do kind of, that's a whole nother talk in terms of how to talk to people differently about their substance use in this more organized way. So again, backtracking in time to not nearly, now 2 decades ago. So for me, 2006. And a literal structural solution we have for people experiencing homelessness and substance use, which is known as Housing First. So how many of you have heard about Housing First as a model of care? Okay, so the majority of you here. So often interchange with permanent supportive housing, but not all permanent supportive housing operates on Housing First principles. And this building here that you see is 1811 Eastlake, which was the first single site Housing First project in the country. And owned and operated by the Downtown Emergency Service Center, that they are the largest providers of housing and health care for people experiencing homelessness in the Puget Sound area. At the same time, on the East Coast, there was other Housing First kind of operating in parallel, Dr. Samson Barris and his work, but there was no single place where apartment buildings or houses where everyone was in the same space. And so this is one of the highly visible, often cited examples, often called harm reduction housing. It offers immediate, permanent, low barrier housing with supportive services on site if people want those. They do not have to accept them to receive housing. And many people who are living in Housing First are individuals who identify with having disabilities or serious substance use problems, as well as psychiatric symptoms. So this is a different model than the traditional model that we used to have, which was if you can be treatment compliant, we'll give you housing. So if you can stop using, you can live here. But as soon as you start using, we're gonna unfortunately have to kick you out. I will say, I'll just be careful about what I say, but I do think that we are shifting away from this model, and I'll talk a little bit about that in a minute. But Housing First basically flips that treatment compliance piece on its head and says housing is a basic human right. It should not be a reward for good behavior. And this model was adopted into federal policy in 2009 based on a lot of the work that was happening to evaluate this kind of model. It's a model that we know works. The question is, how can we scale it in a way that is not under threat? This model of housing did not come without controversy. Susan and I sort of clipped some of the newspaper articles that were coming out ahead of when this housing program opened. It launched December of 2005, but you can see here there are articles in 2003, 2002, because they were sort of getting the Downtown Emergency Service Center was advocating for this kind of model. And so people were definitely not happy about having this type of housing in their community. What is it going to do to the community? And I'm sharing this with you because I think that when you are working in these spaces or doing research in these areas, you have to be prepared to be an advocate and a voice because we have this platform. I'm being guided by science. I did not walk into the Addictive Behaviors Research Center. To be honest, I didn't even know what harm reduction was. I trained as a cognitive and experimental psychologist. I was using a model that Alan developed around placebos to understand the effects of physiological and psychological effects of substances. And it was only through the work that we did and the understanding and the human components and the science that told us that these models are working. So when you know that a model is working, you have to be prepared to speak about it, to advocate. I've been to legislative sessions. I've been to the White House to share our work on action. That was in a day where you could say harm reduction in the hallways. I'm not sure that that's available now. So I do see that there is a pendulum swinging back towards models that we have tried before, I would like to highlight, and that haven't worked. And we are coming up with these effective solutions. But if we can't, if we don't have the infrastructure, then we're going to see failed policies. We're going to see things like what happened in Oregon when they tried a harm reduction approach but didn't have the infrastructure in place where then politicians could say, see, harm reduction failed. This was a bad idea. But they didn't have the structures in place. And I know there are people who can give way better talks on why certain propositions did not go the way that they were intended. But we have to have all the structural pieces in place in order for us to move forward and to do good public health work. So in the original study that actually brought me to this work, it was an evaluation of 1811 Eastlake. Because of all the controversy, the executive director reached out to Alan and said, hey, I met you at a harm reduction conference. This is what we're trying to do. I'm willing to be wrong. If this is harmful for people, I want to know and we will change our model. But can you, as a researcher, put a team together and figure out if this model is working? And so that was our charge. We were assessing whether this model of housing helped to reduce alcohol use and related problems and harm, reduce public spending, and improve people's lives. And of course, the executive director of DESC at the time, who's long passed away now, was also an aspiring politician. So he knew how to talk to other politicians, and he knew what some of the initial outcomes that he wanted to test were, because those were kind of the points that he thought, if these outcomes prove to be true, then I can say, hey, we saved you money. So I hate that human lives are translated sometimes into these outcomes. But we did look at, were there reductions in public spending? Were there reductions in hospital use, jail time, all of those various things? And I wanted to just give you a little bit of a picture of what people's alcohol use look like in this house. So this house specifically, there's now 19 of these houses in Seattle alone, and then also lots of single units, so SROs, single residential occupancy, something like that. So, which is kind of more the scattered site model. So the street medicine team that I went out with today, they were going to places where people have their own rooms, maybe have a shared kitchen and bathroom. And a scattered site housing first model is kind of low barrier, and a team, an ACT team, come to you and help support you with your various needs. And I'm not sure why I'm telling you that now. So, but anyway, oh, I know why I'm telling you, because this specific house was focused on, there was a lot of discourse and discussion around public intoxication in Seattle. They had a 10-year plan to address public intoxication. They were seeing that a lot of the same people were accessing various services that were available in Seattle. They had a sobering center, so there would be a van that would drive around at night, picking up people who were passed out on the streets, take them to this place. They could sleep on a mat, get a cup of coffee. If they were experiencing delirium tremens or anything like that, there were at least medical professionals that could help them. The ERs were kind of having people cycle through them, the jails. So people wanted a solution. And they thought, okay, well, let's have our first house be focused specifically on people who have alcohol use problems, and also are experiencing chronic homelessness. So that's the 1811 signature, is people who primarily their primary drug was alcohol. And to give you just an idea of their use, 90% of those people met criteria for alcohol dependence. Their mean typical drinking quantity was 24.4 drinks per day. The peak drinking quantity, which means the most that they were drinking, was 39.9, so 40 drinks, which would put most people on a concrete slab somewhere, but people's tolerance, they have incredible tolerance. 65% of this population experienced lifetime delirium tremens, which comes when you go through alcohol withdrawal. And I want you to note here that people had a mean of 16 episodes in treatment. So clearly something was not working about the treatment system. And the average age of mortality, I believe in this this is now 20 years ago, was I want to say it was like between 48 and 52 years. And that's very humbling as someone who is in that age category herself now. But that is not acceptable for one of the wealthiest countries in the world. We need to be doing better than that. I wanted to provide the corollary, if it will, my screen will move, because this is often left out of the picture, particularly when we're working with populations that have some sort of marginalized identity. It's their stories of resilience and strength. And I do feel like we should be leading with these. I think we're so used to a culture of approaching things from a deficit-based lens. And I really think that we could be reframing and looking at things from a strength-based lens and really trying to bolster those things. What I've learned about working alongside people experiencing or with lived experience of homelessness are their sense of humor. Some of the funniest people that I have met, and the fact that they can maintain that sense of humor with a lot of their life experiences is simply remarkable. There's a sense of community, of real strong cultural identity, and a street culture. Resourcefulness. Some of the people I work with are the most resourceful people I've ever met. They do what they need to do to survive, and that mental toughness and kind of this ability to survive against all odds that individuals bring to the table. So 20 years of research has taught us that harm reduction housing, like Housing First, works. Here we saw the first of with the first evaluation, which is the leading one there, Housing First resulted in over $4 million in taxpayer savings over its first year of operation. Keep in mind, this is a house that has 75 units, so 75 people total. Of course, this is an incredibly health vulnerable population. So people did die during the study because, they are now visible and able to be counted rather than passing away on the streets. The findings are remarkably consistent. The science tells us that Housing First dramatically improves housing stability. It reduces high cost service utilization like ER and jail. It does not worsen substance use or psychiatric symptoms. And in fact, even, when people move inside and they're not told what to do or how to necessarily you do not have to stop using the substances that you're using. We still see reductions in substance-related harm and improvements in quality of life. And I think that's, for me, why this moment in time is so surreal and honestly quite disturbing. We are watching a backlash against this model, and some entities are actually blaming homelessness on this model itself. Because they're saying it's like you're only giving people housing, you're not requiring them to do X, Y, and Z. What is that message? What kind of message is that sending? Somehow the message has gotten lost, and there is now this new narrative that giving people housing makes them worse, and is not doing it. And I want to just say that is not true. The science does not bear that out at all. And if Housing First and other permanent supportive housing goes back to the way it was before with all these high barrier and high conditions placed on it, I think it will push people back out onto the streets. It will increase visible homelessness. It will shift people into overburdened emergency departments, and we'll see like the prison industrial complex even more so than we're seeing it now. I think that at the same time, there are proposals now floating around also to move people into more coercive institutional settings or involuntary treatment compounds. I'm here to say those models are more expensive, they're less sustainable, and historically associated with rearrest, relapse, and overdose death, which is the opposite of what we're trying to accomplish. We have done those things before. They are not working. I don't know. I was a memory researcher before I really launched into being an alcohol and substance use researcher. So maybe we just have really short memories. Maybe I'm not sure. But when I talk about 1811, I'm not just telling a story about one building in Seattle. I'm talking about a scientifically validated evidence-based model as a solution for homelessness with people with co-occurring substance use and mental health issues. And so I am very privileged to be able to speak to these things in my positionality. And so I do try to use my platform to do that so that I can speak to the science and share what I know, because I am allowed to do that at a state-funded institution. I can speak to the science, and that's what I'm here doing today. And more importantly, I think, in addition to what the science tells us, over and over and over in all of our studies, Housing First is seen by the residents who live there as the thing that saved their lives. And I think we need to remember that too. We are human beings in this world together. And when you're in proximity with people and you hear their stories, you often think, gosh, if my life had had just 3 different factors, maybe I would be in this position. And I think we're all closer than we realize. Most Americans, by the way, are 1 to 2 paychecks away from their housing stability. So think about that kind of tenuousness. And yeah, just think about that, I guess. Okay, so that was a lot of research and publications and effort was focused to establish a very obvious fact, which is often a lot of psychological research. Housing people experiencing homelessness works as a solution for homelessness and should absolutely come first. People need stability before they can ever make any other changes in their lives. And so the natural question, and this is an area I've spent a lot of time, is, well, then what comes next? I guess I should be keeping, how am I doing with time?
15 more minutes.
15 more minutes. Okay, does that give time for questions too?
No.
No. Okay, I will try to move this along. So I guess this question of what comes next or what comes second is where I spent the last 10 years probably of my career trying to answer. So people move into housing. Do their substance use issues disappear? Do their mental health issues disappear? What do you think? No, no, they do not. The reality is that people are still experiencing harmful drinking, harmful substance use, and also unchecked like mental health is still, is present. And so what can we do to mitigate and minimize some of the negative consequences that people are experiencing? And that particular question really led to the Life Enhancing Alcohol Management Program, or the LEAP for short. The aim, really, this was part of a K award that I received back in, I'm really dating myself, but yeah, back in 2011, I believe. And that was really to co-develop and evaluate programs that reduced alcohol-related harm and improved quality of life for people that had experienced chronic homelessness who were living in housing first settings. So we used our CBPR framework that we now apply to almost all of our studies, and we turned to people with lived experience and expertise of the conditions that we were trying to solve for, asked them what they wanted to see happen. I remember explicitly sitting in a room with the executive director and the housing program manager. Alan was there as well. And the executive director turned to my colleague and I and said, okay, well, you two are the substance use and the alcohol experts. What do we do now? And we were like, well, actually, we know more experts in this area and they're living in your housing, in the housing that you are operating. And so we would like to go and ask them what they think. And so we did that. We spent a lot of time in that community and documenting interactions, interviewing with, talking with the residents that live there, bringing food and showing up for different community events. We interviewed residents, staff, management, and just learned as much as we could from the lived experts. And then we formed that community advisory board made up of resident leaders in the house, people that really expressed interest when we were talking to them and interviewing them and wanting to be part of the solution, giving back because they felt that they had been given so much with their life circumstances and the housing that they were receiving. And then once we then used our qualitative research, like we did this very systematically. We would bring our findings to the community advisory board. They say, oh, you're kind of off here. No, this is a shared experience. And then we ended up designing kind of larger programmatic elements that people wanted to see within these housing first settings. And then we conducted for the pilot during this particular phase, a non-randomized control to just kind of see if there was a signal and what that looked like. I want to humanize this too. The mayor at the time renamed the street that 1811 was on as Bill Hobson Way. Bill Hobson was the Housing First champion. This is our community advisory board. What year was this? 2016, our community advisory board. I want to note, because people are so vulnerable, that out of 8 of the members that are here, that were our community advisory board members, 4 of them have passed on. So this is the reality too. I know you all in street medicine see this. People are really medically vulnerable. And so, but I think their spirit definitely lives on in this work. And that is a charge I have, to keep it in the community and benefiting the people for whom it was designed for. So ultimately, okay, I'll talk for like 3 more minutes and then I'll pause so that we can have questions. But ultimately, through the qualitative research and analysis, we kind of came up with these 3 areas of 3 components of the LEAP. So leadership opportunities were really important. So being part of that community advisory board, and these were voted upon and appointed members. And then we had also staff and management as well in the room of these community advisory boards, because you can have a pure advocacy group, but if you don't have people in the room that actually have decision-making power, we couldn't do and implement a lot of the things that we wanted to implement. So it was a real trust building, because we've tried to, I mean, that's a whole nother talk too on how to build a community advisory board and how to work with different hierarchical structures, because we cannot ignore that they exist. We had people in the room that were the landlords, technically, of people who were pounding their fists on the table and saying, you know, we don't trust you. And so our job as kind of third-party people coming in was to facilitate how to break down those power structures in that room, but also acknowledge that they're there and work to try and not create more harm. You know, if something was said in the meeting and the housing program manager didn't like it, we didn't want our community advisory board members to then inadvertently be punished through policies in the house. So it's a tricky game. And it took, I mean, this is why this work takes so long, because there is so much trust building that is inherent in making this kind of work happen. So anyway, so we had leadership opportunities as kind of one of the main themes. And so we had that appointed advisory board, but then we had open meetings, and they called the reason they're called LEAP researcher meetings is that's what the community wanted to be called. They wanted to also be called researchers. So we had a monthly meeting where anybody in the house could come and learn about what we were doing, give their feedback, share their views, ideas, all that kind of stuff. And then the second category, meaningful activities. So this is kind of a main component. You know, you learn that people moving inside after 20, 30, 40 years of living on the streets, they are skilled, they have interests and passions, so many creative souls, artists, chefs, poets, writers, and people wanted to be reconnected back to those things. So we were able to access the resources that we had or the people that we know to sort of bring in this programming that people wanted to see in the house. It transformed into an artist collective. And we hosted several art gallery shows and had different entities host those. And then that was a means of participants getting paid and honored for their time and work. We had writing groups, we had poetry groups, we launched a community garden. We also had speaker series. So people were like, well, how do I advocate for my rights in housing? How do I get connected to lawyers? So sort of like that casework you might do as a clinical social worker, kind of bringing those people into a forum where now we had trust. So there was proxy trust in the information that was being shared. And then the third part was the recovery and healing, alternative pathways to healing from abstinence-oriented places. So this kind of larger programmatic elements provided a platform for so many of our studies to launch. Based on that, that is actually where we initially recruited people to tell us about treatment. What would treatment look like in your vision? What would you want to see? And we were able to develop a harm reduction treatment model that is now has been clinically tested in trials, is evidence-based, is something that we're working on disseminating. We have partnerships. There are a lot of community members who identify as American Indian, Alaska Native, disproportionately represented amongst populations experiencing homelessness. They were like, we want a talking circle. So we had to find access to and brought in folks from a different university, partnerships for Native Health, to help trial harm reduction talking circles. And what did that look like? And how is that, how could we be culturally sensitive? And those studies are still going. And now we're working with Cherokee Nation on some work through NIDA. So I think that I have so many more slides to go through, but this is sort of the gist. I have data and numbers to show you about how effective our harm reduction treatment model is, about the LEAP program in general. We just finished a 5-year cluster randomized controlled trial of the LEAP with 10 different housing sites. I fear this may be a COVID casualty, but we launched in February of 2020. So much of this work has to do with building relationships on the ground. And unfortunately, because people were housed at the time, we were not deemed as essential staff. And so we actually had to pause the study and lost about a year and a lot of momentum. We tried to shift to online and Zoom meaningful activities. But guess what? We also learned that in one of the best tech cities in America, a lot of people we were working with did not have access to tech literacy. So they may have had a phone, but it didn't always work, the building that they were in, or their so we held over 100 meaningful activities spaces over Zoom. And I want to say that 0 people came. We would call people that we knew, who our community advisory board. So they had a little more means, they would answer the phone. But boy, we know so much more now. So I'm excited. I'll be reporting the results at RSA this summer. I'm so really excited to look at the analysis. I don't have, we went from 500 participants to 160. I mean, so many things interfered with this particular study, but I think that we're going to learn, we've already learned and are going to glean a lot of information from that period of our history as well. So I think I'd love to give people time to ask questions so I can, leave with some of the human elements here. This community garden that was launched, zine that we because now the funding is over for this study, we've been trying to train DESC staff on how to run all these things, and we actually got a grant to do some implementation. That's on pause because of a certain mechanism type that has not been passed, is passed through Congress, but not through the Senate yet. So I am going to pause myself and see what questions people have.